Good afternoon, everyone. I'm very honored to give this presentation as a 2021 NIDA awardee. And I want to say thank you very much to the ISAM Neuroscience Interest Group for organizing such an excellent symposium. In the next 15 minutes, I will present a recent article published in Biological Psychiatry, Cognitive Neuroscience and Neuroimaging, titled Alcohol Binge Drinking, Negative and Positive Variance System Abnormalities. Alcohol and drug misuse is a very pervasive problem. The relative cost to society of alcohol misuse is huge. Alcohol itself accounts for almost a third of all the costs associated with addiction. And when you look at the cost to society, it parallels cancer, tobacco, and HIV. The scope of the problem is big. There are about 16 million people with an alcohol use disorder, estimated to cost about 250 billion per year. 3 million deaths from harmful of alcohol every year, with approximately 6 deaths every minute. In every emergency room, particularly on a Friday or a Saturday, maybe half of the people are there because of alcohol. Half of liver disease is caused by alcohol. There are liver transplants being done for patients at the age of 30 years due to alcohol. Over the last 10 years, this has been increasing frequency of hospitalization due to binge drinking. And by the age of 20, almost a quarter of young adults report regular heavy episodic binge drinking, which is associated with a 13 to 19-fold increased risk of developing alcohol dependence. Many of us will know that the famous actor Robin Williams struggled for all his life for addiction, including alcohol-related issues, and another well-known singer, Amy Winehouse, died at the age of 27 years old after drinking too much alcohol. I've been interested in answering this question. So what is really the mechanisms that lead people to drink excessively and continue to use drugs despite increasing risks and dangers? The beginning of my entire level of inquiry started with this definition. So substance misuse is defined as a chronically relapsing disorder that is characterized by a compulsion to seek and take a drug or stimulus, loss of control in limiting intake, and the emergence of a negative emotional state, such as dysphoria, anxiety, irritability, when the access of the drug or stimulus is prevented. Dr. Coop and Neurobiology, George, are essentially the main source of inspiration that allowed the start and definition of this project. Essentially, the main neurobiological model of reference is this one. The blue areas represent the brain regions affected during the binge intoxication stage. These areas have within system or reward system changes in pre-addiction, where an individual consumes an intoxicating substance and experiences immediate reward effects. This probably is directly linked to changes in basal ganglia function. In red are brain regions involving withdrawal and negative affect. These regions have between system changes in drug addiction and include beta nucleus terminalis and central nucleus of the amygdala. These regions are particularly involved in the stress response to adverse events. Green regions represent the prefrontal cortex, involving cognitive function and the preoccupation and anticipation stage of addiction. So apologies for the psychology lesson, but these two definitions are very important. So positive reinforcement is defined as the process by which presentation of a stimulus drug increases the probability of a response, such as drug craving or drug approach consumption. In contrast, negative reinforcement is defined as the process by which removal of an aversive stimulus, negative emotional state of drug withdrawal, increases the probability of a response dependence induced drug taking. Another very influential person is Dr. Solomon, who first described opponent process theory. This is a theory of normal motivational and emotional reactions to rewarding and aversive stimuli in humans and animals. However, he recognized it was also relevant to drug misuse. Dr. Coop built on opponent process theory, focusing in particular on alcohol and the development of dependency, particularly studying the changes in brain systems that occur during the development of dependency. It is also relevant, of course, to other drugs. So, for example, you take a drug and you experience an elevated mood state, such as high, but when the drug wears off, your mood overshoots and becomes low for a brief period before returning to baseline euthymia. If, however, the drug is taken repeatedly without allowing full recovery of mood to baseline, then the high becomes less and the low becomes enhanced. In dependency, these changes also involve a progressive drop in the range of positive to negative mood that occurs, so that the positive mood no longer occurs at any time, and only different amounts of negative mood occur. To make mood less negative, more drug is taken, and this transiently improves things at the expense of worsening the allostatic state in the long run. So what goes up must go down, and if you use too much dopamine episodically, you end up with a dopamine deficit adaptation. In addition, though, Solomon's opponent process theory and Cook's allostasis theory predicts that there is also a between system change, which is increased vulnerability to stress. Dr. Volko reported in early PET imaging studies that there was a decreased D2 receptor availability and dopamine release in the striatum. This decrease was seen across all addictions, independent of the substance. So, for example, cocaine, methamphetamine, alcohol, and heroin. Preclinical studies show that manipulating striatal dopamine signaling, particularly at the D2 receptor, can evoke impulsive behavior. Furthermore, both impulsivity and low striatal dopamine transmissions are predictive of drug self-administration. Prolonged abstinence from drug use may be associated with some recovery. This recovery of the within-system allostatic reward deficit was associated with prolonged abstinence. The National Institute of Mental Health Research nomenclature RDOC provides an innovative framework to investigate mechanisms of mental illness, whose main aim is to develop new ways of classifying disorder based on dimensions of observable behaviors and brain function. It wasn't originally designed to encompass addictions, NIMH being separated from NIAAA and NIDA, but I believe there is no reason why it shouldn't. This framework was developed during a series of workshops and is characterized by 5 broad functional domains: positive valence system, negative valence system, cognitive system, social processes, arousal, and regulatory system. Each construct is investigated using multiple units of analysis, which include genes, molecules, brain, circuits, behavior, and self-report ratings. Studies in patients and in general population samples have reported dysregulation in substance misuse, but only a few have utilized the RDOC framework. So the full idea is to link subjective symptoms to a specific brain system, facilitating translation. So the main objective of this work was to test for both positive valence system and negative valence system abnormalities in alcohol binge drinker using an RDOC framework. And this was done using this allostasis theory prediction of blunted within system and abnormal increase between system responsiveness using an RDOC approach. So we combined reward and loss avoidance instrumental learning paradigm during fMRI, and MRI spectroscopy was used to test for hypothesized functional brain abnormalities and GABA glutamate abnormalities in alcohol misuse. So 2 brain circuits are conceptualized as having allostatic changes: the brain's reward system and the brain stress system. During drug non-dependence, the reward system is in a normal state of activity, red, and the brain stress system is really not engaged, gray. During the transition to dependence, the brain reward system becomes increasingly blunted, gray, and the brain stress system becomes overactive, red. Here, I have also highlighted changes in the activity of dopamine, GABA, glutamate, and serotonin levels, which have been reported from preclinical studies. This cartoon illustrates the effective changes in Snoopy produced by the stimulus week at work. Another way of explaining this might be allostatic mood changes if Snoopy habitually binge drank alcohol at the weekend, like many humans. So binge drinkers were recruited before the binge and scan on Friday, and after the binge and scan on Monday. The neuroimaging sessions involve the acquisition of structural functional MRI, magnetic resonance spectroscopy, and various clinical measurements such as alcohol use, anxiety, and mood. It's very important to say that the binge drinkers recruited in my study were not drinking during the week. So mood is on the vertical axis. In A, there is a standard pattern of affective dynamics produced by delivery of an unconditioned stimulus. In B, you can see the hypothesized changes in the affective state in an individual with repeated binge stimulus presentation. So the hypotheses were tested with individuals scanned on Friday, a pre-weekend binge, and individuals scanned on Monday, post-weekend binge. So this is the instrumental learning task that was used. You can see that the task incorporates 3 possible outcomes: rewarding, win, aversive, loss, and neither win nor loss, nothing. Volunteers were told that the main aim of the task was to win and to avoid losing points or voucher as much as possible, and volunteers had to learn to do this by trial and error. So win trials had two possible results: you win a voucher or nothing. Lose trials had two possible outcomes: you lost voucher or nothing. One pair of fractal images was therefore associated with each type of outcome, and the association between a given pair of fractal images and either win or loss was randomized across participants. So the probability of winning or losing fractal pairs had a fixed high probability, 70%, and a fixed low probability of 30%. So I tested the following hypothesis for binge drinkers in comparison to controls. Binge drinkers in comparison to controls had blunted activation to reward gain in the striatum, and binge drinkers had increased activation to unsuccessful loss avoidance events in the anterior mid-cingulate cortex, bilateral insula, amygdala, hippocampal complex, and periaqueductal gray. During win events, healthy controls strongly activated the nucleus accumbens. In contrast, binge drinkers exhibited blunted reward link activation in the nucleus accumbens. Comparing healthy controls with binge drinkers during win events, binge drinkers had significantly blunted activation in the nucleus accumbens. For reward gain events, the alcohol use score rating negatively correlated with the strength of activation in the bilateral nucleus accumbens, reward versus muffin signal. So in other words, the more problematic there were alcohol use and the more blunted binge drinkers were with regards to the nucleus accumbens reward activity. Additionally, there was a negative correlation between win-related reward activation and higher anxiety. This means that the more anxious binge drinkers were, and the more blunted nucleus accumbens reward activity was present. During unsuccessful loss avoidance events, healthy controls deactivated the bilateral hippocampus. In contrast, binge drinkers did not. Here in B, we can see there is an absence of the activation in bilateral hippocampus in binge drinkers and a significant between group difference for the contrast binge drinkers greater than control. During loss events, binge drinker activated bilateral insula and anterior mid-cingulate cortex, and the extent to which activated correlated with years of alcohol use. In other words, the more years of alcohol use they self-reported, the stronger the activation for loss avoidance in binge drinkers with a p-value equals 0.02. Periaqueductal gray negatively correlated with units with p equals 0.02, and the ratio of GABA to creatinine with p equals 0.006 during unsuccessful loss avoidance. Inconsistencies are, of course, present in the current literature on substance misuse, highlighted by recent meta-analysis by Logetin, regarding differences in brain responses to reward in reward anticipation versus reward outcome phases, as well as abnormalities in different stages of addiction, such as binge, dependence, and abstinence. The majority of the previous published literature focus on drug-related stimuli, which are clearly overactive in the nucleus accumbens. The interesting finding of overactive anterior mid-cingulate cortex with loss is very interesting. One has the magnitude of which correlated with years of alcohol use. So the anterior mid-cingulate cortex is strongly implicated in negative affect, cognitive control, and pain from previous animal studies led by Dr. Vogt, and from a meta-analysis published in Nature Review Neuroscience, and it is part of the negative evidence system. Lesions in the anterior mid-cingulate cortex, anterior cingulotomy, have been used to treat treatment-resistant depression without alcohol or substance misuse. And we have argued the anterior mid-cingulate cortex as a causal role in negative affect and cognitive control, and this work now is published in Brain. So in the context of alcohol misuse, the anterior cingulate has been linked with alcohol preoccupation and craving. Cingulotomy has been used for treatment of alcohol dependence, and anterior mid-cingulate cortex deep brain stimulation has more recently been reported to suppress alcohol craving. So in conclusion, the results support theoretical prediction of blunted within system reward abnormally, and abnormal increase between system, stress system, brain responses in alcohol misuse in humans. Binge drinkers also show decreased striatal reward activity relative to control, and binge drinkers had increased brain responses to unsuccessful loss avoidance in the amygdala and hippocampus. So what I suggest is that future translational neuroimaging studies in alcohol misuse and alcohol-dependent humans are indicated, particularly investigation of between system abnormalities and the RDOC negative evidence system, which are likely important for the more severe stages of alcohol misuse, but have been largely overlooked in clinical research. So I really would like to thank my advisors, Professor Steele and Baldacchino, and our collaborator, Prof. Coop. These on the right, you can see that these are our funding that we acquired to run such a big study. So I really would like to thank you everyone for paying attention. And if you have any questions, please drop me a message at my email, tolomeoserenella@gmail.com.